Good evening, everyone. Welcome to Foundation for Democratic Reforms webinar series, Crisis is Opportunity. I am Vritti Bansal, representing Foundation for Democratic Reforms, headed by Dr. Jayaprakash Narayan, who is also a panelist with us here today. The reason why FDR is conducting this discussion today is the COVID-19 pandemic has caused several disruptions and has exposed major fault lines in India. We understand that there is a crisis, but this crisis presents an opportunity to push for reforms, at least in the key governance areas of healthcare, agriculture, and big city management. Today's webinar, which is the first of the series, is on rejuvenating healthcare system in India. Our primary healthcare system has lost its credibility, and there is a heavy reliance on hospital care. Our healthcare system is inefficient and ill-equipped, and its impact disproportionately falls on the poor. Government-run insurance programs in the long run increase fiscal burden without commensurate benefits. Given India's dual challenge of fiscal constraints and high share of communicable and non-communicable diseases, we need cost-effective interventions and models that are accessible, affordable, and built on our existing strengths. To discuss this in detail, we have with us today on our panel very 5 distinguished speakers who are keen on sharing their insights on the subject. First, we have with us Dr. G.N. Rao, an eminent ophthalmologist, founder of L.V. Prasad Eye Institute, Hyderabad, also inducted into Ophthalmology Hall of Fame by American Society of Cataract and Refractive Surgery. We welcome you, sir. Next, we have with us Dr. Henk Bekedam, former WHO representative to India and a leading expert on universal health coverage and infectious disease control. And he is joining us from the Netherlands. We welcome you, sir. Next, we have Shri Keshav Desiraju, former Union Health Secretary and currently serving as the chairperson of the Governing Board of Population Foundation of India. We welcome you, sir. Next, we have with us Dr. Srinath Reddy, President of Public Health Foundation of India, a Padma Bhushan awardee who has served on many WHO expert panels. We welcome you, sir. Finally, Dr. Jayaprakash Narayan, physician, former civil servant, and General Secretary of Foundation for Democratic Reforms. We welcome you, sir. Thanks to all our speakers for joining us today. Before we begin, my colleague Shweta Chandra will share with you the format of the webinar. Over to you, Shweta.
Thank you, Reddy. Just one moment while I share my screen. I hope everyone is able to see the screen. First of all, I'd like to thank all of our esteemed panelists and our participants for joining us. Before we begin, I would like to just briefly list out the format of the webinar. So each speaker will get 10 minutes to share their insights, followed by a session summary by Dr. JP. Post that, we will have a 45 minutes question and answer session. Kindly use the chat box to ask your questions during the webinar. We will first take up a few questions posed by the participants during registration, and then we will move on to the chat box questions. Kindly keep your questions brief and also mention the speaker who you want to address your question to. Before we begin, I'd also like to say that I'm extremely happy to announce that we've had over 500 registrations for this webinar, and that's extremely exciting news. And I hope that we are able to continue this momentum going forward for our subsequent webinars, which is on agricultural supply chains and also on big city governance. I again thank you all for joining this webinar, and I'm sure that it's going to be an extremely engaging and fruitful session for all of us. Now I'd like to call upon Dr. JP to give some opening remarks, and over to you, Dr. JP.
Thank you, Rithi and Shweta. And I extend a very warm welcome to the distinguished panel. These are men and women of great experience, wisdom, insights, and tremendous understanding of how the system works and how to reshape it. And their passion and commitment are self-evident. We're grateful to you, sir, to all of you for giving us this time. We'll also have Sujata Rao, former health secretary, who will be, I think, who is already there with us as a participant, but she'll also be sharing her perspectives. And thank you all for the participants. A large number of people from across the world have shown enthusiasm. So much so that the capacity is now, they're not able to handle. There's a limited capacity. We expect only 500. but there's an overwhelming response. And next time, probably we'll try and accommodate more people. Thank you all for that. The series is crisis as opportunity, as Paul Romer said. A crisis is a terrible thing to waste. What I propose is make a brief case for some significant changes, relatively easy, low cost, but with good outcomes, some changes, and see the perspectives of the various experts who have done enormous work in the healthcare field and generate a debate in the country. And then together, on whatever we broadly arrive at, see how best we can nudge the political and governance system to bring about those changes. The proposals that we are making are very modest. They are economical. We understand that no, ideally we should get 5 or 8%, 10% GDP and healthcare from the government, but that's something that will never happen. Therefore, when we're spending 1.3% now, can we get another 0.5 or 0.6%, but judiciously applied, sensibly applied? Because anything more than that is at this point perhaps unreal. Effective, however you deploy the resources must get the best outcomes for the resources we deploy. They must be non-disruptive. We're not trying to destroy what's available. Try and see how best we can build on our strengths and roll out in a manner that, if necessary, we can have a mid-course correction and we can change. Because there's nothing written in stone here. It's all about pragmatism and sensible outcomes based on past experience and best practices. With that perspective, I won't go through the slides in an orderly manner in detail. There's no need to go. That time also is a constraint, and the panelists are experts, and many people are committed to healthcare in India. They understand many of the problems. So we can take you through the logic. In many ways, India has lucked out. Next slide, Rithi. India has lucked out in the COVID crisis so far. If you take the global incidence or the morbidity rate, the severe disease COVID, or the mortality, so far the numbers show that India is actually lucky. It doesn't mean that luck will hold, or it might hold, we don't know. There are all kinds of postulates that probably we are genetically resistant, luckily, for some of these viruses, relatively related to other populations. Maybe other causes are there, but it's immaterial. As of now, it appears that we are somewhat lucky. But even then, there are parts of India where we are not able to cope with this. If we had the same morbidity, next slide, same morbidity and mortality as these some of the other countries, it would have been impossible for us to handle. We would have had probably close to 400,000 or 500,000 deaths by now. We would have had maybe 5 million or more actual COVID patients, not merely COVID positive cases, but patients. Our hospital system simply is incapable of handling that. We all know. Next, please. So what we are saying is there are 3 issues that emerge from that. The first is another such crisis which is more severe, where the morbidity and mortality rates are even higher than, let's say, in case of coronavirus or SARS-CoV-2. Indian health system will be paralyzed, will collapse. Second, in the absence of a credible primary system, primary care and family care system, the situation is compounded in India because people are panicking. For instance, dengue season, we're again going to get this every year, we now have it. When we were doing medical school, studied Dr. Rao Garu and Dr. Srinath Garu, we never thought of Aedes mosquito being endemic in India. We were all thanking our stars. Thank God there's no Aedes, there's no dengue fever, there's no yellow fever, etc., etc. Now Aedes is endemic in the country. Now, in each dengue season, thousands of people are flocking the tertiary care teaching hospitals, even if they are normal viral or other fevers, for fear it might be dengue. The system is overwhelmed, and the doctors have no choice but to admit them, and then quickly send for tests, and then after they get the confirmation that they're negative for dengue virus, they're discharging them. Otherwise, they're treating them. Now, in such a situation where the primary care is virtually inadequate or in most cases absent, the crisis is compounded. And third, of course, even in normal times, without any pandemic or some other problem, we actually have a permanent crisis in healthcare. That's the reason why we thought this is an opportunity to look at some significant changes at a relatively low cost. Next, please. Next, please. The problems of Indian healthcare, we all know, very low expenditure, very high morbidity and mortality. 2,000 kids are dying every day in this country below 5 years of age. Over 800 tuberculosis patients every single day. Large number of people suffering from malaria, you name it. But the last item, 55 million Indians, they are descending into poverty every year because of healthcare crisis, because of out-of-pocket expenditure or lost income because of healthcare problems. What it means is, from an economic point of view, if only we took care of this, if only we had a credible healthcare system at a relatively modest cost, reaching everybody. If nothing else is done in the country, poverty will be eliminated in about 10 years' time. There cannot be a more compelling case. It makes no sense whatsoever that we're not paying enough attention to healthcare the way it should be. We are, of course, among large economies, absolutely at the bottom, not something we should be proud of, as Dr. Rao was mentioning just before the session began. But we also have tremendous strengths and opportunities. It's not that we are very weak. And next slide, please. India can do, next slide, can do a lot better because we have large number of doctors, nurses. There's tremendous fascination for these jobs. And we have world-class pharma industry and vaccine industry at the lowest cost to supply. And our medical care interventions in tertiary care are among the lowest cost in the world. And world-class standards. Take Prasad care. Take many corporate private sector institutes also. There are maybe some problems, other problems, but in terms of quality of care and the cost, they're absolutely top-notch. So we have some significant strengths if we know how to leverage them. Next, please. For reasons of convenience, we're looking at three broad areas: primary care, secondary care, tertiary care. Obviously, it's a continuum. Primary care, obviously, the first point of contact, etc., etc. Preventive care, family planning, maternal and child health services, and simple early diagnosis and management of non-communicable disease, and so on and so forth. Tertiary care is sophisticated interventions, whereas secondary care in between, any hospitalization with simple, relatively simple interventions, including simple surgeries like a double surgery. Broad, crude division for reasons of convenience. Our broad argument is that secondary care, already the country, the union level and state levels, they hit upon some kind of an approach. The Ayushman Bharat program and Arogya Shri is ideal for secondary care, but not for tertiary care. Already, underwear state of Andhra Pradesh, now AP and Telangana, they were the pioneers in this Arogya Shri. In some form or the other, that has now become increasingly a popular model emulated by the rest of the country. That is, with some tweaking, clear demarcation, secondary and tertiary care. Today, Arogya Shri and Ayushman Bharat include tertiary care interventions. We believe that's not in the right direction. Later, when we discuss tertiary care, maybe we can look at it for half a minute or so. And if you universalize secondary care, ultimately the rich and those with insurance, they will take care of themselves. But access must be universal so that A, the bulk of the people, even outside the ration card system, who actually need this support, they will get it. And B, the people with voice, if some of them start utilizing it, the quality will improve and accountability will be greater. It doesn't make any sense to limit it only to people with certain ration cards and all that. Even the poorest of the poor, I know for a fact even in AP and Telangana, where the access is much larger than in much of the rest of the country, there are many truly poor people who don't have the documentation or the ration cards, and they're terrified. If something happens, hospital care is required, some catastrophic illness, what will happen? So it doesn't make any sense. Additional cost is only limited, but the benefit is significant. And integration of union and state models, because the states started, some of the states started first. I think there's no full integration yet. I think that will get into over a period of time. But most important of all, limited to only secondary care interventions, not tertiary care, because that is a bottomless pit. The cost will continue to skyrocket without any commensurate benefit in terms of healthcare outcomes. It's a controversial point, but I think this has to be stated. Next, we'll go to primary care. Next, please. Primary care obviously involves these four things: first point of contact, long-term focused care, comprehensive care, coordinated care, and including referral system and integrating the secondary and tertiary care. We have 26,000 PHCs, next please, in the country. They're doing a very difficult job with limited resources, particularly in family planning services and immunization and some of the other interventions and cold storage. They're doing a credible job. But because of the limitations of resources and personnel and access, it's not able to deliver the full results. And you obviously cannot have a PHC for every 5,000 population. It's a little absurd. And in any case, accountability is an issue in the absence of competition and choice. You know how the government functions. In PHCs today, some function well when the doctor is motivated, some others, they simply exist. Similarly, some of the community health centers, some function well, some simply exist. Therefore, what we're looking at is how do you, at a moderate cost, ensure reasonable outcomes and accountability and some kind of a say for the community and the patients. That is the whole idea. Next, please. The broad model is, you can go to next slide. Let us think of a small town. This applies to 80–90% of India. Let us say there is a small town, like Andhra Pradesh, Telangana, Mandal headquarters or something. It need not be even a municipality, but a big panchayat or a small town. Within, let's say, a 10-kilometer radius, there is, let's say, 50,000, 60,000, 70,000 population. This is a realistic scenario in much of India. We will not ask the doctors to go to every village. It's unlikely. But certainly, given India's current situation, 200,000 doctors fully trained with MBBS, etc., but unemployed or unemployed. India is the only country in the world where hundreds of thousands of doctors are unemployed, even as the healthcare system is in shambles. It requires genius to mess up things this bad. If they are encouraged, if they're willing to participate in the program, let's say about 10 people set up practice in that small town, but subject to certain standards and yardsticks. They take care of all the primary health needs. The payment to them can be on per capita basis as in Britain, or it can be on outpatient basis, which is much more measurable, maybe initial phase, that is a better model, so that there is a decent income. And there is competition and choice because the patient or the families can choose any one of these 10 practitioners, or even they can even go to another neighboring town where there are another 10 practitioners available. They can decide whom they want within reasonable limits, so that automatically competition, choice, the ability to serve better and therefore engender confidence and trust, and therefore get more patients and more income within reasonable limits, again, without overcrowding. That will be addressed. And the system will take care of accountability issues. If you do a costing, and here, of course, we'll have to have a nurse and maybe a lab technician or somebody, simple diagnostics. And with more sophisticated diagnostics, Andhra Pradesh already has experimented with private sector participation, outsourcing diagnostics. I don't know what Dr. Srinath Reddy feels, but what little I have seen across the state of Andhra Pradesh intensively, I find it's working pretty well. There's a high level of satisfaction among clinicians about the quality of reports and the testing. So I think now India has reached a level where even if sophisticated diagnostics are not locally available, private sector can step in if you create a judicious mechanism. But prescription and drugs available to them there itself, and referral services. The basic idea is a patient will not go to a higher level hospital ordinarily unless it's an emergency without a referral. Today we all know from AIMS, where Dr. Srinath Reddy was professor, and where Dr. J.N. Rao, he did his post-graduation. I mean, 10,000 outpatients. Most of them have absolutely no need to go to an apex tertiary hospital at all. Only in India it happens. We have to reduce this overcrowding and have a system which actually works with the right kind of deployment of resources. If you look at the costing, next please. At a decent income, assuming about 150 rupees per outpatient visit, Delhi model is showing 120 rupees. We're assuming a little higher is required to attract people. This covers the cost of the doctor, the nurse, and the lab technician, etc. With some other cost involved in terms of basic initial infrastructure training, etc. It's coming to, if you assume 200,000 such clinicians practicing within the system, it's coming to about 45,000 crores annually. If you add a few other incidentals and training, it comes to under 50,000 crores. And I think it's extremely well spent money, provided the system actually delivers. And it's not at the cost of other improvements. For instance, the informal practitioners in India, the untrained or uncertified practitioners, if they can be integrated, there are many expert committee recommendations, etc. If they can be integrated judiciously, they can be add on to this under physician supervision. All kinds of things are possible, but this basic thing at a relatively low cost, because personnel are available in the country. And I think India has come to a level where it's possible to create this mechanism. And in this model, it looks like the doctor will get to the primary level about ₹1,00,000 net income per month, which is not bad at all. And after some years, if they want to do something hospital practice, they can always move there. But I think this is a decent enough income and it's attractive enough. And the market mechanism that we have introduced will ensure there is some degree of accountability. Nothing is perfect, but I think it's worth pursuing this model. Next, please. Let's go to tertiary care. One of the things that surprised me personally when I went around the hospitals, did some intensive study of the district and teaching hospitals and some of the area hospitals, 100-bed hospitals, is for every rupee spent by the public hospital system, even this discredited, overcrowded, underfunded public hospital system, where the hospitals actually are working. I'm talking of things being reasonably there, teaching hospital, district hospital, etc. For every rupee spent, the society is getting 4 rupees value. There is one case in Parvatipuram in present-day Andhra Pradesh, where the society is getting 10 rupees value. We costed all the services rendered by them at the low end of the private care. And we quantified each of these things. It's coming to be quite impressive with all the deficiencies. And tertiary care, private sector, or insurance-based system simply will not work beyond the point because the per bed capital cost in high-end tertiary care in private sector is 1 crore rupees. The billing per annum per bed is 50 lakhs to 1 crore. There's no point blaming them. They're not greedy or anything. Even if there's no malpractice and inflated billing, modern healthcare in tertiary sector costs enormous amount of money because technologies are dramatically getting advanced, but the cost is skyrocketing. The benefits are commensurately less compared to expenditure. India is not at the stage where we can spend crores and crores on tertiary care. Not that we should ignore it, but we should look at public systems, strengthening it, enhance its capacity, give more resources, make it more flexible, make private practitioners and consultants of repute come and practice there, make it attractive and hospitable for them, and allow private sector investment through private financial initiatives. So they get an assured return, so the government burden and improving infrastructure initially is not there. But basically make it a government-funded, government facility of care. That is the basic idea. And the rich will anyway have their own insurance and they will do whatever it takes. And overseas patients and others, they will all be able to support the private high-end hospital care system. But we cannot make it the mainstay for the publicly funded tertiary care system. That is the broad argument. I know it's very controversial. I know there will be a lot of resistance, but I think we should look at the data and then decide ultimately what is the best course for the country. If you look at the costing, the teaching hospitals today, I'm not talking of some apex hospitals, but generally about 8 lakh rupees are what they are getting per bed. Oftentimes, if the sanction strength is 1,000 or 1,100 beds, I'm sure Keshav knows this, there are 1,500 beds, 1,800 beds, because there's no choice. There's overcrowding and doctors cannot deny admission to poor patients who are in distress. And with that, they're handling it. If we simply increase this over a period of 3 years or so, to let us say in district hospitals from 6 lakhs to 15 lakhs per bed per year, and teaching hospitals from 8 lakhs to 20 lakhs, some 2.5 times in a period of 3 years. A modest thing. Now, if you get more money, 30, 40 lakhs, it will be wonderful. But at least that much, if it's done judiciously with a lot of flexibility, it appears that we can significantly improve the quality of care, particularly because the primary care system is filtering many cases and overcrowding. This is probably going to cost about 25,000 crores or so. The teaching hospitals and district hospitals together, it's going to cost us about, I don't know. Next slide, please. Together, these two, the primary care initiative and the tertiary care initiative, it looks like about 90,000 to 100,000 crores per year. Is a reasonable estimate. It's not a very conservative estimate. It's not also very liberal. It's a realistic estimate in my judgment. But we can do some tweaking. I think it's a good opportunity. Even at this cost, the final cost will not be more than 1.8% of GDP. The current expenditure in public system plus added expenditure will not exceed 1.8%. I think an excellent return for the amount spent. And even then, India will be one of the lowest spenders in the world. I'm sure Dr. Srinath knows and Dr. Bekedam knows. 1.8% is a steal. We are now spending incredibly low amounts. I think this is something affordable. If with improvements and flexibility, this is taken up. I think I will stop at this. Do we have any more slides? Yeah, this is
yes, sir.
only one last point. This will meet 80% of the needs of the country. I'm betting that 20-25% people, for whatever reason, either because of class reasons or they have incomes or they don't trust the public system because it's lost credibility significantly over the years, they will depend on private system and they have the resources. Let's not worry about it. It's actually a strength of the country. I think that we're not looking at a perfect solution for everybody. There are a lot of things to be added as and when the political system has the appetite for change and the resources to deploy. And one economic benefit independent of healthcare is, if you take United States and Britain as two examples, if you take relative to the population and relative to the workforce, how many people are engaged in healthcare, India deploys the smallest number of people, 0.23% of the population, altogether total health workers in public and private system, from the biggest to the smallest worker, and only 0.5% of the total workforce, the lowest, 1/10 and 1/20th of the British and American standards. If it becomes somewhere near half a British standard, even then we will have 10 to 15 million new jobs only in healthcare. I think we have to sell it as an economic issue and jobs issue, in addition to healthcare issue and distress issue and poverty issue. Then I think there is a greater chance of the political system understanding and embracing some of these things. I will close with this. May I request Dr. Henk Bekedam to now offer his remarks and comments and expert advice.
Thank you very much, Dr. Narayan. It's a pleasure listening to this, and I would like to congratulate you also for organizing this. And I fully agree, from every challenge presents an enormous opportunity. And I think this is a very important part also to pursue some of those issues which I think I know from the panel members that I do know and are passionate about, is that indeed there is a need to invest a lot more in health. I think India is now around the 1.3% of GDP, and that is by all standards is low. And I think you made the point that very clearly. And I think in addition to your presentation, you also came up with a paper, and therein also you mentioned some of the reasons why it's so important to invest more in health. And if you don't mind, I always come up with 7 reasons. The first one is people do forget about how many people are actually going into poverty because they're ill. And in India, you have a pool of people who were not poor before, and there are 55 million who are moving into that pool. It is, by the way, not on an annual basis. It's a pool where people going in and out, because there are also people getting out of it again. But there is never less than 55 million people. And can you imagine that the government has been focusing on poverty, which is extremely important, but at one sector they allow people to go into poverty. So it's extremely important. It's also important from an economic point of view. If you reduce out-of-pocket expenditures, then in certain countries, and I think it's India also the same, because people are unsure about, especially about health, but generally also about education, people are having savings. And because when people are having savings, they don't spend it in the economy. So that's another reason why I think it's so important that if we give people more assurance, if themselves or their loved ones, if they are ill, that they don't need to go into poverty, then perhaps some of the savings, for instance, putting it in gold, but then they can, for instance, they can buy a new bike for their son, etc., etc. So this investing in health, I think, is one of the passions. And for sure, through myself having been involved and was a WHO representative in China during the SARS, I always on my slide, one reason why we need to invest more is to make sure that we have a system that can early detect an infectious disease and which can better respond. And that investment, and I think nobody in the world, no economist will at this very moment argue anymore that investment is extremely important. I think globally we are in a recession, and never ever seen before from all the people who are now online. We've never seen this before. So investing in health is extremely important. I will not further dwell on this one. But it's also true I've worked with many governments, and often we have been asked but where do you start? I think a few things which I would like to add on then from your presentation. Now, first of all, I think you might have also followed the debate here a bit in India. You have a National Health Policy 2017, which is wants to move towards 2.5% of GDP. But the Minister of Finance and all those people have already said that you can't even spend what at this time on what you get, even a little extra. Now, one thing is for sure true, and that's what with governments that I've worked in before. If you have a small engine and you give more fuel, then sometimes it can't burn the fuel. So one thing is now very essential. In order to get a bigger engine, some of the things you mentioned very clearly, you need to look at infrastructure and you need to look at the healthcare workforce. That's a very important part of the engine, and with that one, you make it bigger. And therefore, you can also consume what needs to be done. And of course, it's not only because of just consumption, but also what there's a need for. So I would like to get back to this one. In your paper, and you emphasized a little bit less in this presentation, what's also important, while the strengthening of where the public funds goes, there are a few things which I would like to mention. The public funds should go there where the private sector, where the market doesn't work. The market is not interested in safety and in quality. The market is not interested in the poor. The market is not interested in something what it can't see, like prevention. So we need to make sure that the public funding goes there where the market has no role. I've never worked in any country where the private sector is so important as in India. And therefore it becomes part of the solution. But where the public funding should focus on in those areas where the private sector is less engaged in and will not be engaged in. So therefore, I think it's so important. Another issue which I think you recognize, especially in your paper, truly, that in urban areas, do not forget, we need a primary healthcare system there too. That's all very important. But please do allow me to comment on a few things. One thing which I strongly believe, having worked in many countries, is that we need to be careful to think that doctors are ready to go to rural areas. They're not ready to go to rural areas in all the countries that I worked. So we need also to look at the mid-level healthcare workers for the rural areas. I do think for the urban areas and the primary healthcare centers, we need to call upon them. But for the reality part, the mid-level healthcare workers are very effective. We wrote even a paper about it and has very good results. And that looks also something which I would like to mention this very moment. I fully agree from what you have been mentioning that you need to build on the strength of the country. And there's one thing which I would like to mention. In your paper, you mentioned a bit more. The importance of that you have an information system that is capturing all and unites people. A patient, if this patient is in the primary healthcare center and it goes thereafter to a secondary or tertiary level, then that patient is the same patient and that data needs to move with that patient. And the integrated health information platform is a very strong platform where with a unique patient ID for all over, for whichever level you're going to, it's very important. And the vision is also that with it, it will become an electronic medical record for the patient. And of course, with all the privacy issues is an issue that needs to be looked into. But I would like to mention one thing else. We should not forget the need of the hour, the fight against COVID. COVID is not going to go away. This virus is around, and as long as we do not have an effective vaccine, we are very grateful that some medicine seems to be more effective to at least reduce the number of deaths. But the vaccine is the main factor that can change the whole pattern of the outbreak itself. So the part of the investment needs to go in strengthening the public health surveillance, strengthening infection prevention control, and with it also the infrastructure. I have visited, when I went to the States, I visited infectious disease hospitals. Now, in most states, they are in a dismal state. This needs to be invested, and I was very happy the Minister of Finance, at least on the 17th of May, was at least alluding that one part of the infrastructure needs indeed to go over there. But also the system and technology. And employment remains a very important point, which I also would like to argue for. In addition to what you have been saying, I believe that every single state should have a health investment plan. I call it a SHIP, a state health investment plan. And they need to cover 4 areas. And some of these areas you have very well covered, and thank you also for that. One is the infrastructure. And believe it or not, I'm not with WHO this very moment, but as WHO, we were even in India, we say that you need to invest in the infrastructure in India because some district hospitals are in a very poor state. In some places people have to walk too far to get even access to primary healthcare level. So infrastructure is a very important part. And this time I think there's also one opportunity. We can do it better. It can be greener, it can be sustainable. And I think what we need to do now, and there's also links to the COVID, but it is for essential services very important, we need to make sure that all healthcare facilities have proper water and sanitation. Unfortunately, there's still many centers who do not have proper running water and sanitation. Now, this is where Swasbharat, they need to extend. And I think we need to call upon the Prime Minister himself and the ministry to get involved in this part. That infrastructure is part that needs to be invested in very strongly. We need to do a little bit of thinking how we need to start adopting in the infrastructure in a society where we need to keep the physical distance. I lived for myself for 4.5 years in Delhi. Now, if you go to one of the better private clinics, there is no way that you can keep social distancing. I'm a big guy, but it's for sure true. When I walk in a corridor, I touch patients, I touch people. There's no way. So we need to really think about it. Also, our facilities should be better organized and should be more spacious, that it doesn't become the place where you unnecessarily start coming too close. So the infrastructure is a very important part. The second component is employment. And the 10 million part is a bit much at this time moment, I would say, but having said so, Dr. Srinath, Reddy and myself, and together also with Nitya York and the Ministry of Health, we're working on a paper that we do think that in the next coming 2 or 3 years that you can employ 1.8 million healthcare workers easily. Partly because of the vacancies, this has not been filled. If you look, for instance, at UP, 50% of the A&Ms, they are not employed. They are officially there, but not employed. They need to be employed now. And what we need to be doing now, we have seen that states are reluctant to start employing. They rather do the short-term contracts. We need now to convince them, and I think the government most likely needs to come up with a kind of guarantee that they will be able to deal with this recurrent cost. They need to be there. They need to be there for the COVID. They need to be there for the primary healthcare. They need to be there as a stronger health system. So we believe that on the A&Ms and the IDSP, even in IDSP, we have many vacancies. It needs to be done immediately. In addition, India, except for Tamil Nadu and Maharashtra, the public health cadre is actually non-existing. We need to start working on public health. Prevention remains the best. And that's a part I think should also be an opportunity. And indeed, I fully agree, this employment part is extremely important, and it's also good for the economy, but it's definitely also important for health. The third one is on medical products and technology. You touched upon very much on for instance, the diagnostics, which is extremely important. But I think the ventilators and the oxygens and the IPC equipment, the infection prevention control is also important. I think we need also to continue to start investing in digital health. This is an area where we need to look at, and some telemedicine is a reality in order also to have some consultation. But there's one thing which, the other thing is the laboratory. The laboratory network needs to be far much more. I'm very proud of India, how they have been able to scale up the number of tests on COVID, but actually it's still, of course, on the low end. And so the lab infrastructure needs to be strengthened, and that can be done and needs to be done. Now, there's something very specific that I'm going to mention. And I've shared it also with the government when I was still in my job. We need to make sure the flu vaccine, anybody who will have a fever from the next 1 year will always be suspected as a COVID case, rightly so. Now, first of all, you need to do the flu vaccine because the healthcare work especially, you don't want them to become ill. They need to continue working. Let alone that anybody who will get a flu, they need to be isolating him or herself for 2 weeks, independent of a test is positive or not. So the flu vaccines for all healthcare workers, for all people working in services, those ones who do get close contact with patients and people, and also the pregnant women. The H1N1 remains a killer for women. So the flu vaccine, I really would like to say, let's do this. Let's make sure that we'll make sure for the next flu season that's there. The fourth one is an information system. I already mentioned a few things, but here's important. We need to start connecting a patient who's in a PMJ in insurance and a person who goes to their primary health care. It's the same patient. They need to have the same unique ID. Their record needs to be everywhere to be available, and this is important. So also what's happening in the PMJ, they need to be there. Now, another point, so this is the state health investment. I do believe that the state needs to reflect on all these four items and describe what they are going to do specifically in their state. And I do believe there needs to be an additional funding to be available. But initially, when I started discussing it with the government, they also said, oh, it's already there. No, I think there needs to be additional funds to become available to have the state health investment plan up and running. Now, the other thing which I would like to share with you is the social protection one is on the PMJ part. Now, the PMJ is now covering 500 million or 100 million families because of the COVID. I do believe, and this figure is not scientifically, but we have a lot more people who are now in poverty. And I do believe that some of them who were not in poverty are now in poverty because of the crisis. So I do think the PMJ coverage needs to move towards 700 million. I've got only one issue to add, perhaps I'm going over my time, is on the urban areas. The urban areas are a challenge. The urban slums, especially when the social distances is not possible, this is a challenge. Now, one thing, we do believe that I would like also the Svas Bharat to go over there. We need to make sure that there are sufficient water points, that there's sufficient sanitation points. The Svas Bharat can not only look at the rural area, well, in the middle of the town, people have no access to proper facilities. And that's extremely important overall for health, but definitely also during the COVID. But thank you so much. If I have gone over time, I apologize. But I'm still very passionate about India and I would like to share. Thank you so much.
Thank you, Dr. Bekedam. I know that you have a time constraint before I let you go. A couple of things. One is the 10 million employment you're talking is not government employment. That's neither feasible, perhaps not desirable. If you build a decent enough healthcare system, there is that much of demand and need, and the private sector also in picture. Not that everybody will get a very high-end employment. Even 10,000 rupees a month is a very decent employment in most parts of India. Just to give broader perspective.
No,
only one question I have for you, with your expertise. There are some countries even poorer or roughly comparable to India in terms of incomes, which are doing a very credible job in healthcare. Vietnam comes to mind, then Cuba, people talk about it very greatly, and then Sri Lanka and Malaysia in our neighborhood and elsewhere, etc. So are there some interesting models, very briefly, from which we can learn in India, leveraging our strengths and making good quality care accessible to people at a low cost?
Absolutely, and it's very consistent from what you have been talking about. And Dr. Srinath Reddy is also over there, and we have been a long-term relationship on this part as well. From investing in the rural areas is absolutely crucial. You need to make sure that there is a first contact where people have trust in, where people are being treated properly, where when they go to the facility, there is somebody. And if there is somebody, that somebody is qualified. And if somebody is qualified, if they give some medicine, that medicine is available. And that is often not being the case. So in that sense, the investing in the rural areas is extremely important. But it's also true, and I like also the balance that you took. You need also to have a credible system. A credible health services is not if you can't deal with some of the more complicated issues too. So I do think, but it's all of these countries that you're mentioning, they have invested a lot more. I know there's one country where I worked at this time on, India has a very different relationship with it, but I still would like to mention as an example, where in China, when I started working there in 2002, China started spending less than 1% of GDP as a government. They are now spending 3.5% of GDP in the health sector. And they have now set up a far much stronger public health system to detect, etc. These kind of things are there, but all the other governments that you mentioned, they have invested a lot more. So the only thing is what you now need to guide the government, and I like also your calculations already, and that already looks very balanced. We need to talk now to the politician and get them over the fear. Spending in health is not an expenditure, it's an investment. And I think that's the part that we need now to start changing. We need to go back to the people who, I had a lot of respect for the late Arun Jaitley, the Minister of Finance. But this was one discussion that I had with him from, please do not see health as an expenditure. Health is an investment. And I think this is the part where I'm so happy to join you during the discussion. I will try to make even a bit more time available because I'm very interested also to learn from the others.
Thank you very much. Dr. Srinath Reddy, you have been a tireless champion of an integrated, sensible public health system in the country. And you yourself are an outstanding tertiary care specialist in India's premier healthcare institution and in a most sexy field of cardiothoracic surgery. I would like you to offer your remarks, but with particular emphasis on a couple of things. How do we make this dialogue one of the central issues of our policy making in this country? And how do we nudge the governments at the national and state level towards recognizing the healthcare crisis instead of merely treating it as one news cycle issue and one temporary crisis management issue? Process now. You have to unmute your. Okay.
Thank you very much. I will start off by agreeing wholeheartedly with Dr. Henk Bekedam that health is actually an investment for not only protecting the economy, but also an important accelerator of economic growth. I think that debate has generally ended now in terms of health actually being seen as yielding economic dividends, but not fully recognized at the policymaker level. In fact, if you look at some of the recommendations of the Commission on Investing in Health, the Lancet Commission of 2013, they come up with the statement that every dollar invested in health will have $9 to $20 return on investment. 9 in low-income countries and $20 in middle-income countries. So even assuming that as a low middle-income country now, we should see at least $10 to $12 of investment returns. Much more importantly, of course, is the whole issue of ensuring health as a human right as well. And both the arguments are confluent in trying to make a strong case for greater investment in health. And now we also recognize that without that level of investment in public health in particular, but also in terms of healthcare, we are going to be seeing also a periodic threat to the economy, as COVID-19 has very clearly shown, that your economic productivity is greatly shut down, human resources are wasted, and ultimately we will pay an economic price as well. But having said that, I would say that we do require to make the case more strongly. And definitely, I would say that in terms of health, I would agree broadly with most of what you have said, Dr. Jayaprakash Narayan. The only question is, while we are bringing in the public sector, which should be much more strengthened, but also bringing in the private sector as a partner which actually fits into the overall framework of universal health coverage with clearly defined deliverables as well as accountability mechanisms, whether actually a fee-for-service mechanism will still be something that we want to maintain. Because if we do bring in the private sector into the universal health coverage mechanism and continue to pay in a fee-for-service manner without any appropriate regulatory mechanisms, there is an incentive for performing more procedures, more consultations, more patient visits. So we ought to be looking at how best we can move towards a capitation fee system, even as we are bringing the private sector in at various levels of care, but especially at primary and secondary. And certainly tertiary care is something that we can look at as relatively less dependent in terms of incorporating a partnership mechanism. I would like to propose what I would call a Dashasutra Pranali, which is firstly, improve the design and delivery of primary health care, which is a very strong subcenter which has technology-enabled non-physician healthcare providers, mid-level healthcare providers. What has been proposed for the health and wellness centers should be implemented in real earnest. Secondly, even the primary health care centers and the community health centers also should be strengthened. It's not only the health and wellness centers, which undeniably is the most important frontline healthcare post, but all of them should also be linked up very well, clearly. And we must promote integrated care without splintering them into different national programs in terms of both integrated care as well as with continuity of care assured. And as you rightly said, a gatekeeper function to be played by competent primary health care. The second is strengthening secondary and tertiary levels of healthcare. I'm fully in agreement with you and Dr. Bekedam, but I think the strongest priority should be given in that sector to strengthening of district hospitals, which not only should be upgraded in terms of skills, but they should also become now new training centers for new medical colleges, nursing colleges, and allied health professional training centers that not only bring in strength to them, but also ensure that some of the underserved states and underserved districts of this country will actually now have better district hospitals. The third, I would say, is also to create networks of primary, secondary, and tertiary healthcare providers. You need horizontal integration as well as vertical integration. If you're bringing in the private sector at each level, then do create a properly defined network of primary care providers at each level, both public and private, functioning under the aegis of the Universal Health Coverage Scheme, but also establish vertical bidirectional linkages with appropriate referral and follow-up mechanisms. And all of them must have the mandate from the Universal Health Coverage priorities set by the government. Then I would say that the fourth one is to develop a multi-layered and multi-skilled health workforce. And here, as I said, apart from technology-enabled frontline healthcare providers, we require to invest a lot in a variety of healthcare providers, from basic doctors and specialist doctors, from basic nurses, nurse practitioners, as well as specialist nurses, and a multitude of people working as allied health professionals. And you must ensure, in order to reduce the regional imbalances, where there's no point in saying that the South will have multiple colleges, and even if you want to employ them, they'll only be employed there. You create also an opportunity for an all India recruitment through an all India cadre, which can actually position people across the country to reduce some of the regional imbalances, even as new medical colleges and nursing colleges are coming up in the underserved areas of the country. And I would say also that even for emergency services, we do need to create a capacity for like an emergency task force among our health services. Then we must provide free drugs and diagnostics, at least in all public healthcare facilities. But certainly if the private sector is entering into a publicly financed healthcare provision system, then they should agree to it through a pooled public procurement mechanism for purchasing the drugs. Not only the public sector, but even the private sector should buy from that pooled public procurement mechanism so that it can reduce the costs and pass on the benefits to the patients. Unless we reduce the cost of medicines and diagnostics, will not make much impact on out-of-pocket healthcare expenditure. Of course, we do need to increase public financing for health. The government has said that it's going to go to 2.5% of the GDP by 2025. Now, with the current COVID crisis and the state of the economy, that may not happen, but we must at least try to increase the front-end spending so that we have, as Henk very rightly pointed out, you can't put in a lot of fuel into a small engine. You do need more front-end spending in order to build the capacity of the health sector for more absorptive capacity and better utilization capacity. And of course, as we allocate more money, we also need to increase the allocative and utilization efficiencies. As late Professor Ramalingaswamy used to say, we need more money for health, but also more health for the money. So therefore, that brings in also better allocative efficiencies, particularly for primary health care. We need to improve our regulatory and information systems. Without that kind of regulatory strength, you cannot run a universal health coverage program. And certainly in terms of information systems, we do need a lot more representative real-time data, which enables not only decision making at the state capital and the national capital level, but even at the district level. Those information loops must be readily available for rapid response. Then I would say very clearly that there has to be an active engagement of the community. Unfortunately, our systems are totally vertically driven by the government without adequate participation of the citizenry. And what we need is people-partnered public health and people-partnered healthcare systems. Without that, we are not going to see that level of engagement, both in terms of their participation, but also having them to monitor and hold the services accountable. Then finally, we also need to act on the social determinants of health. I don't think we should only talk about healthcare delivery system as our priority. Even while we are talking about primary healthcare and we are talking about health promotion and disease prevention as important elements of that, we also have to ensure that the government pays much greater attention to the social, economic, environmental, and commercial determinants of health. Otherwise, we'll continue to have more disease created by other sectors, and then we'll continue to require more and more money for the healthcare element of our health sector. So I think all of these elements need to be brought in very clearly and carefully into the play. You did mention in your presentation that we are blessed at the moment with a fairly strong health workforce numerically. I would like to differ a bit with that. Firstly, we are very short, whether we take doctors or nurses, in terms of the ratios that have been recommended internationally. But of much greater concern to me is the total asymmetry in their distribution. Many of the colleges and consequently many of the people in the health workforce are concentrated in southern and western India. A good deal of central, northern, northeastern India doesn't have the required number of doctors and nurses. Certainly the ratios are extraordinarily abysmal. So I think we need methods of even correcting the health workforce, not only quantitatively in terms of numbers, qualitatively in terms of skills, but also in terms of distributional equity across the country. And that is something that needs to be done. Otherwise, we'll have this rather astounding figure that 8 states of India account for 70% of maternal deaths.
Thank you.
Thank you.
Thank you, Dr. Srinath Reddy garu. I entirely agree with you about the manpower asymmetry, regional asymmetry. And as you said, I think an all-India cadre from the government side, and perhaps developing a national market rather than a regional market for healthcare providers. These two will address it. Eventually, I think in each region we can enhance the capacity. Thank you very much. Dr. Jayaprakash garu, you have a unique blend of experience of building a world-class tertiary care institute in eye care, and then taking up the secondary and primary care with great efficacy in several states, Andhra Pradesh, Telangana, Orissa, and other neighboring states. And I keep saying publicly, along with a few like-minded friends, that the southern Indian eye care providers, like Prasad Eye Institute under your leadership, and maybe Shankar Netralaya and Arvind Netralaya, together deserve maybe much more than many other institutions a Nobel Prize. Outstanding work you have done. So how can we emulate these practices in the general healthcare at an affordable cost with great efficacy? I think we have a lot to learn from your own leadership and guidance.
Dr. Jayaprakash, if you could kindly unmute yourself.
You have to unmute.
Okay.
Okay.
Okay, what I'll do is to run through our model, which more or less has put in practice many of the principles that have been discussed by the preceding 3 speakers as ideals for a robust healthcare system. Can we have the slide?
Yes, yes, I'll share it.
What we did over the past 2.5 decades is to try and create a model in one segment of medical care, that is eye care. Next. This is an integrated integrated model of eye care delivery, starting from the primary care in the remotest rural areas, care of the problems at the advanced level, in the advanced tertiary level at the centers of excellence. The idea is to create high quality model that caters from simple screening in remote areas to management of all complex diseases at the very top. A kind of care that is appropriate to that level, that's available to all people, affordable and accessible, without at any stage compromising quality. Quality is the underlying strong point of our system. Next. So the principles that govern our model are what have been discussed already today. Comprehensive care that encompasses prevention and promotion, treatment of diseases, and rehabilitation of disability, vision disability. Second is commitment to quality. Third is take care as much closer to the doorstep of the people as possible, making sure that this care has continuity with active community participation in the rural areas. Next. At the very bottom, we work with a population unit of 5,000 people. And as has already been alluded to by Dr. Beckman and Professor Srinath Reddy, we work with appropriately trained people for various functions. At the very bottom, we work with ASHA workers, A&Ms, health workers, and in some places, school teachers, who act as our volunteers and keep an eye on the eye health of these 5,000 people. They are our representatives for vision health in the remote rural areas. Next. At the next level, we have center-based primary care. Here we have a model that we developed about 30 years ago called Vision Centers, where it's a fully equipped eye center with a one-year trained technician, a high school graduate trained for a year from the same local community and put back in their community, providing high-quality primary eye care. So this person also has a career advancement opportunity. This center serves a population of 50,000 people. The principle is eye care of good quality should be available to all people within a 10-kilometer radius. Next. More recently, we have begun to leverage technology and teleconnectivity. So a lot of early diagnosis and the need for referral can be determined right then and there. The only revenue stream here is sale of low-cost spectacles, ranging from 100 rupees to 400 rupees. And the small profit that you generate from that takes care of the operating expense of these centers. Next. The next level is the secondary level. We call them generically service centers, mainly because service is the main thing here without any other distraction. Here, there are 1 to 3 ophthalmologists depending on the need and the demand, assisted by a staff of 25 to 30 people. 80 to 90% of them again are drawn from the local communities, trained and put back in their own community. Here, a lot of eye care is provided. Nearly 85 to 90% of all causes of blindness and vision impairment can be tackled here. Next, more recently, we have begun to migrate some of the tertiary care elements to secondary care, like corneal transplantation, by providing appropriate infrastructure and specialists traveling from tertiary centers to the secondary centers so that this care becomes available closer to the people. What we have is an integrated model of secondary and primary care. With each secondary care center, we have 10 vision centers linked to them. Within this entire thing is within a radius of about 50 kilometers. Secondary center having a population of 500,000 people. 10 primary care vision centers, each serving 50,000 people. Working with 100 vision guardians, each serving 5,000 people. So each such complex serves about 100 to 200 villages. Next. These are then linked to tertiary care training centers where cases are referred if that kind of care is required. And at the very top is the center of excellence where anything done anywhere in the world is done. Here we have strong training of the trainers. Next slide. Research, model development, resource mobilization, etc. Next. All this is done in 3 states predominantly of Southeast India, Andhra Pradesh, Telangana, and Orissa, with 1 center in Karnataka and Ballari. Now have a complex of 210 centers, 185 primary, 20 secondary, 3 tertiary, and 1 center of excellence in Hyderabad. The functional activities of this entire network, next slide, is through these 10 functional arms of the institute, closely integrated and working together. And with this kind of a functional structure, the entire pyramidal model of eye care delivery we've been able to deliver. And we touched about 30 million people over the past 33 years, trained many all over the world, all cadres of eye care personnel. So we work with the principles of comprehensive care, eye care team approach, with each team member performing a different function so that it becomes efficient and cost efficient. And then sustainability, community participation. So all these elements are incorporated into this model. That's how we created this a particular model for eye care. And I strongly believe a similar model can be developed for any area of healthcare. It's the same principle that have already been discussed today. Primary care, given its due importance, a strong segment of secondary care, supported at the top by the tertiary level and centers of excellence for appropriate training and meeting our research needs for the country. These tertiary centers and centers of excellence can also should participate very actively, in my view, in the policy formulation for healthcare for the country. And such active participation by the leaders of the centers of excellence will go a long way in coming up with a very robust policy for healthcare for our country. Thank you.
Thank you, Dr. Rao. Fascinating and very successful model, not merely theoretical. Just one brief question to you before I move on to Keshav Desiraju.
Yeah.
On the back of an envelope calculation, what would be, you think, the cost per million population or whatever, on the basis of your experience for the whole healthcare system, roughly? What's the kind of money we're looking at?
For the healthcare system or eye care system, you're asking me?
No, eye care you already have experience, but if you expand it to healthcare,
yeah,
just a back of envelope calculation.
For every million?
Yeah.
For a million population, I think if we invest about $25 to $30 million, we can probably have a robust healthcare system which is self-sustaining. But I think we also have to have a system of cross-subsidization, which we used very strongly and we have been very successful at. Because more than half our patients don't pay anything, zero, and the other half who pay have been cross-subsidizing the operational expenses of the entire network.
Thank you very much. Keshav, you have been at the apex of health policy and administration, and you've been associated with the health sector as a public policy expert for long, even after retirement. How do you make this happen? Or the variants of this happen? There's no one model written in stone. Basically, we all want the same thing. Optimal outcomes with the least resources given India's current conditions. And we all understand the deplorable conditions of healthcare in the country. So what do you see as the feasibility, and what are the constraints in your judgment, and what are the improvements that you consider?
Thank you very much, Dr. Jayaprakash. I'm glad to be on this panel, and thank you for your very comprehensive presentation. And there is no disagreeing with anything you have said, or Dr. Bekedam or Dr. Reddy. I mean, these are fine points, and one has to support them wholeheartedly. I would like to spend the time I have talking about one issue, which is really human resources. You asked, what are the constraints? Now I'm looking at your slide. I think it is slide number 7. You say total number of doctors, 1.2 million, of whom 200,000 are unemployed. Number of doctors produced per year is 50,000. Now, I mean, I've always said this whole business of medical education and Medical Council of India, this is really the elephant in the room. We are not going to be, even with a 1.8% GDP available, we are not going to be able to use this effectively or constructively unless you have qualified people at whatever level who are there manning our posts, as it were. Now, all of us who worked in this area know that the 1990 to 2010, those 20 years were disastrous for medical education in the country, with the opening up of huge numbers of medical colleges. And I don't want to spend our time talking about the Medical Council, but we know what the problem is. Dr. Bekedam said that yes, doctors will not go to rural areas, and this is not true only of India, but this is inevitable. On today's date, we have 542 medical colleges in India. I believe more than half of them are private. Somebody who has paid the fees that a private medical college charges is not going to be available for public service. And everybody knows this. So though we have huge numbers of the kinds you quote, that so many doctors are graduating every year, a significant number of them are not going to come and begin their careers as medical officers in a primary health center. They need, apart from anything else, to repay the debts they've incurred to acquire their medical education. So there's no getting away from this. The way out of here, and this is not an overnight solution, is clearly governments need to invest more in government medical colleges. I am not so, I mean, Dr. Reddy spoke about this, about converting district hospitals, functioning district hospitals to treatment come teaching hospitals. It's a very good idea, provided the clinical services being offered do not suffer. Because if the teaching becomes the agenda number 1 of these converted institutions, then it means that the only available care to millions of people in our country, which is at district hospitals across the country, will come down in quality or availability or reach, which would be a very high price to pay in order to set up a medical college. So we may need to think about this. One problem, I don't know the correct figure, but UP, I believe, does not have more than 10 government medical colleges. All of UP, with its 80 districts, does not have more than 10 government medical colleges. But having government colleges in itself is not going to solve the problem. I mean, again, something else, I don't want to cause offense to anyone, but you cite a figure saying 200,000 doctors are unemployed. I have a horrible suspicion many of them are unemployable. We have to be, the one thing the Medical Council did not concentrate on was curriculum, standard of teaching, because it would be a big mistake to think that every one of the doctors coming out from our 542 medical colleges are of the same quality. They are not. It's a rule of, most people seem to think that a product of a government medical college, because she has seen a much wider range of patients, is probably a better trained doctor. But then, I mean, this is just hearsay. I mean, we don't know whether this is actually so. So, why are people not well trained? Because we don't have the faculty. Everyone here, most people listening to this panel will know that when AIMS was set up, one of its primary objectives was to create teaching faculty for government medical colleges across the country. That has not really happened. Now, new AIMS institutions have been set up. I don't know, I don't have the data, but then most of these new AIMSs have finished, have graduated maybe even 2 or 3 batches. I suppose to be a faculty, they would need to do post-graduation. But whether this increased number of AIMS trained graduates are going to be available as teaching faculty in medical colleges, I don't know. So we really need to find a way out. Maybe at some point, Dr. Reddy will comment about how the NBA, the whole DNB system can add to this. Because so this is seemingly insoluble. We need more quality government medical colleges. This point of time, we don't seem to have the faculty to man them. So how is this to be done? Everyone talks about telemedicine and teaching on Zoom like we are doing a meeting today. I'm not sure that is the answer. So that is one very, very big issue. Second issue related to human resources is that I think Dr. Reddy mentioned, Dr. Bekedam may have mentioned that we do need to have a good, well-qualified cadre of mid-level healthcare workers. This is going to be very difficult. Some 10 years ago, and if Sujata is on this meeting, I hope she will talk about it. Some 10 years ago, there was this, what I still believe was a very good idea of creating within the university system a BSc Public Health. And that these people were going to actually be this mid-level healthcare worker. We were slaughtered in Parliament on this because we were accused of creating cut-price doctors to send to the rural areas, whereas we were going to have properly qualified doctors for people like us living in the cities. I mean, we were given no quarter. The whole thing was shot down. Everybody seemed to think that, this BSc healthcare person was a doctor. And we kept saying, no, this is not a doctor. This is a mid-level healthcare worker, a kind of transition level, somebody at least who will be in a position to identify illnesses where they are occurring and push people in the right direction. But we were not able to get off the ground. So while this is a very fine idea and builds into the recommendation of the high-level expert group of which Dr. Reddy was a member of having a public health cadre, I don't know how it's going to be done. Or how are we going to make this person acceptable? And then, of course, people start talking about Ayush doctors, and I don't want to enter into that controversy here, but I have no difficulty with Ayush doctors, provided they are doing Ayush. We should not have a situation where Ayush doctors begin working in disciplines in which they have not been trained. And it's an easy solution for government to immediately say, no, we will push Ayush doctors to all PHFI. You can do that, but they must do Ayush only. So I think these are very difficult questions in the whole human resources area. The number of government hospitals, the quality of doctors being trained, the ability, and again, I mean, since we are talking, and it is, we have to admit these things, the posting and transfers of government doctors is one of the most lucrative occupations in any state government. I mean, there's no point denying this. Dr. Bekedam says doctors will not go to rural areas. Of course, the state government can post them and keep them in a rural area if it was clear that you could not buy your way out of that posting. As long as it is clear that you can buy your way out of that posting, nobody is going to go to the rural area. I mean, these are difficult questions and no one likes talking about. But if you are looking at the kind of, with moderate increase in resources of strengthening our whole system, these are questions we need to answer. One very last point. You have something on Ayushman Bharat. Whenever people talk about Ayushman Bharat, they're only talking about insurance. The other very important component of Ayushman Bharat are health and wellness centers. Dr. Reddy very correctly referred to them. Now, you have said somewhere that we need, I think I saw a figure of 48,000 crores in order to bring primary health centers to a certain workable, reasonable standard. I think we should compare this with what is the budget they provided for in Ayush. within Ayushman Bharat for the health and wellness centers. It is nowhere near this. You have asked for 48,000 crores over 3 years. It has been more than 3 years since Ayushman Bharat was launched. And they have given some pitiful sum, if anything. I think anything you read that comes out of Ayushman Bharat is full of statements like, it is hoped that, it is believed that. I mean, hope is not a plan. I think, please ask someone, since you do have a figure, ask someone to find out how much have central and state governments between them provided for the health and wellness component of Ayushman Bharat. It's only then that we can understand that they're serious about primary care. That they're very serious about strengthening private hospitals to do Ayushman Bharat is in no doubt. We should be equally confident that they are looking at strengthening primary health centers. One very last response to Dr. G.N. Rao's very fine presentation. I can see how this works, sir, in the context of eye care. But we are also saying at the same time that we should stop this silo treatment, disease level treatment. We cannot have we certainly, of course, need to have doctors doing eye care who can't do other kinds of care, but we do need to have maybe following the same pyramid model, but we have a clear identification of what are the range of jobs they will do or the range of conditions just thinking aloud, this eye care model may work for dental care, for instance, because it's a specialized business with different levels of care, which you need, which nobody seems to have done in the same way in which it has been done for eye care. But if we're talking about primary care, we need a very proper understanding of, at the different levels of the pyramid, what should they know, who will teach them that, who will regulate the institutions that will teach them that, and questions like that. Thank you.
Thank you, Keshav, for the reality check, and particularly for the focus on two areas, the human resource constraints and the fact that the budgetary allocations are pitiful despite grand announcements. As Dr. Srinath Reddy quoted Professor Ramalinga Swami, you not only have to make your rupee go very far and making things happen, but you have to actually put more money into it. I mean, there's no substitute to putting more resources, but wisely deployed. Thank you for a wonderful presentation, and all of you. Now, Priti and Sweta will take us through the questions from the participants. Several questions have come. We have, I think, about 40 minutes. Am I right, Priti, or do we have more time?
Yes, sir. We have 40 minutes.
Yeah,
if all panelists and participants agree, we can extend it for another 10 minutes.
Yeah.
Yeah.
Also, Ms.
Thank you
Sujata
for
Rao
all
has
the
joined
speakers
us.
for such a constructive engagement. Okay.
I'd like to mention that Ms. Sujata Rao has joined us. Ms. Sujata Rao, I have promoted you to a panelist, so you can kindly unmute yourself. Hello?
Okay, let's start off with a question or two to Sujata right away so that we can continue the question answer session.
Hello, Ms. Sujata Rao, can you hear us?
Okay, move on. Time is a constraint.
Okay. So before we begin with the questions from the audience, FDR research team has a question for Shri Keshav Desiraju garu. Policies like universal healthcare have already existed on paper, but the implementation has been far from reality. Given your experience with the government, what is the bottleneck in implementing the same?
Apart from what is already mentioned,
Shri Keshav Desiraju?
Apart
from what everyone on this program has been saying for the last hour, which is only bottlenecks. No, I think if one simply has to cite one, I think it is a somewhat inexplicable lack of interest in primary care. It is always easy for government to look at infrastructure development, to look at secondary and tertiary care where building is involved, construction is involved. One must always be very careful when one looks at government figures of how much they've spent on the health sector. You should always ask them, what have you spent it on? Have you spent it on big buildings? Have you spent it on equipment? Or have you spent it on training? And have you spent it on primary care? So I think the lack of attention to primary care, which is in itself a reflection of the lack of any political interest in promoting healthcare as a public policy, is, I think, a very major bottleneck. If more MPs and more MLAs could fight for increased budgetary allocations, I think things would begin to look good. Yeah,
Thank you, sir. My next question is, thank you, sir. My next question is, we always talk about investing in healthcare, but not much attention is paid to research and development. And West also doesn't focus much on drugs for tropical diseases prevalent in the developing countries. So if I could ask Dr. Srinath Reddy, what can be the way ahead? Sir, kindly unmute yourself.
Well, I think we do require more research in problems which are particularly relevant to our country, and also looking at the equity dimension. Quite often, sometimes we actually prioritize research programs not just on the issue of the researcher's interest, but also when we actually initiate government-funded programs, we look at what we call the burden of disease estimates. That's important, but we also need to look at the equity dimension where some of the neglected diseases need to be attended also, apart from the ones which are very prominent in terms of the disease burden. But having this demand-responsive research conducted by the research community needs constant dialogues between the policymakers as well as the researchers, where ideas can be exchanged, priorities can be set by consensus, and then the progress can also be monitored. But obviously, one of the problems that has also come up is some of our research funding agencies are very siloed, and their committees only decide on the priorities of their committee members, which are not necessarily aligned to all the national priorities. Secondly, because funding from various agencies is again in silos, whether it is within the medical sector or within the social sciences sector or within the economic sector, you don't have transdisciplinary research coming in and being funded substantially. That is where many of the health programs get neglected, because you do not have the requirement, you do not meet the requirement of multiple disciplines working together for producing public health research or even path-breaking medical research.
That answers our question, sir. Thank you. Now at this point, I'll turn it over to my colleague Shweta. Over to you, Shweta.
Thank you, Vritti. So before we get to our chat questions, our participants sent us a few questions during registration. So due to the paucity of time, we won't be able to run through all of them, but I'll pick a few questions. So the first question I'd like to address to Dr. Henk Bekedam. So this is from Dipendra Chetri. So he's asking, India supplies 40% of the world's vaccine at the lowest cost. 90% of active pharmaceutical ingredients are imported and 70% come from China. What can we do to reduce our reliance on China in line with this self-reliant India movement?
Thank you very much for this question. I think it's an issue where the Ministry of Health has been looking at for the last years, at least since my time. That I've been 4.5 years now in India and has just left. I think that this is an issue which I think we need to, that India rightly is looking into. What we saw with the COVID response, just to give you an example, with the PPE, India was highly relying on some of the materials for the PPE. And I give the Ministry of Health, including the Minister of Textile and the Prime Minister's office, a lot of credit that within a few months they were able to organize themselves and are now able to make, I think, 100,000 PPE, high quality, etc. So these are some issues what needs to definitely be looked into. That's an issue which I think the government is doing. But if you don't mind, I even would like to link it also to the research and development part. India has been indeed the pharmacy of the world in quite a few areas. It's the vaccines, it's the generic medicines, and the diagnostics. Medical devices is now coming up. I do believe that India can also do a lot better in research and development of medicines. I also believe that now with the COVID, if you don't mind me mentioning this part, On the COVID, we need to learn. One thing is very clear. We are still learning. We're still learning about the surprises of the disease itself. If you look at the clinical manifestations, it's very different than what we knew about the SARS. Even the spreading of disease. SARS was only spreading when you had a fever. Now we know many more things. I have really encouraged, because India has a great capacity, just like it did with polio. Polio, India got into the research, did research which was important for India, but many of the answers in polio was very helpful for the whole world. Now also with COVID, I really hope that they step up and start looking at many of these issues. Like for instance, the oxygen. It's already very clear that we already know that many people, they feel that they're not ill, but they have very low oxygen. We need to do research. We need to learn more. Important for India how to respond, but also for the world. So I do think there are many opportunities. If you don't mind, I have to go now to the things that are very, really organized. I was happy to join and very proud to be part of this gathering and happy to engage soon again. And all the best. And please do, even when I'm far away, India is in my heart, and we will be with you. Thank you so much.
Thank you, Dr. Bekedam. Thank you for your participation.
Thank you.
Thank you so much.
Thank you. Bye-bye. Bye.
So the next question is by Annapurna, and this is to Dr. G.N. Rao. And this ties into the LB Prasad model of healthcare. So given the shortage of skilled manpower, especially in rural areas, can high school students and college students be given exposure in basic and simple procedures in healthcare so that they become much more equipped and informed and skilled?
I think certainly the college students during their summer times can certainly go and work in rural areas. There are several projects that are already now, very surprisingly, most of such slots are taken by Westerners, not so much from our students. We don't see too much interest from students of our country. We get a lot of letters from students from elsewhere. They come and work in our rural areas, do projects, do a lot of work in the There's plenty of opportunity for them to get involved in healthcare in a variety of ways throughout the country in the rural areas. Not only eye care, in every aspect of it.
Thank you, Doctor. And then the next question is by Rajesh Putta, and this is directed towards Dr. JP. So the high-level group of the 15th Finance Commission recommended the transfer of health from state list to the concurrent list. How efficient is the move with states being the front runners in the fight against COVID? And will the concurrent list create scope for blame game between the state and the central governments? And even Dr. Srinath Reddy, you could also chime in.
I think Dr. Srinath is competent, but before he takes over, I am somewhat skeptical of centralizing the service delivery. We have the example of education. We made it to part of the concurrent list, school education. We came up with the monstrosity of a law, Right to Education Act, which did not even once talk about outcomes. We increased allocations, we had all kinds of things, but ultimately, the quality of education is appallingly bad at the school level. And of course, it's college level, as Dr. Srinath Reddy pointed out, and Keshav Desiraju pointed out. So I think there is no impediment for Government of India influencing policy and improving quality of care. I don't think there is an issue of Parliament having the jurisdiction to make laws in terms of medical colleges, professional standards, skills. Anywhere the Parliament has jurisdiction, it's a national subject. But in terms of healthcare, I don't think a parliamentary legislation, well, that's the purpose of making it a concurrent subject. For all of India, one should fits all model, like the way they have done in the case of education, which actually is diminishing flexibility and diminishing the outcomes. I don't think that's the answer. The government has all the ability to be able to intervene efficiently and flexibly in the current model. Right now, without putting money where the mouth is, after all, the Government of India is only spending 25% of the total healthcare budget, roughly, if I'm not mistaken, in the country. 75% of public health is spent by the states. This is the lowest in all federal countries. Instead of putting money, I think there is an effort to try and centralize the issue and give an impression that they're doing something dramatic. The real issue is not about centralizing the legislative power, but actually designing with the center, union and states participation, a viable model. And we have enough centrally sponsored schemes in India where the union is able to influence public policy through fiscal and other means rather than legislative authority. But I'm sure there is a room for a different kind of interpretation. I don't know what Dr. Srinath feels. Srinath.
Well, I plead guilty to some extent of being a member of that group, but I must confess at this point in time that there was no consensus on this particular recommendation. There was a majority in the team that felt that this was necessary. Interestingly, even there was in the bureaucrats of the health ministry, there was no consensus on this. I agree with you that I believe that it is not proper to have it also centralized. In fact, health requires a lot of planning and implementation and the freedom to plan and implement at the state level. In fact, I would say decentralization even up to the district level would be required. And therefore, too much of centralization can be very, very counterproductive. And I fully agree with that. On the other hand, the central state platforms for consultation must be much better utilized, like the Central Council of Health, which actually brings together the Union Health Minister and the state health ministers and the officials, and even the NRHM review process. All of this, or the National Health Mission as it's now called, all of these should be used much better for building in consensus and for prioritization. But I believe clipping the wings of the states would not be proper. And while the report might have gone in without a note of dissent, I think there was a lot of concern about this particular recommendation.
Thank you.
Thank you, Dr. JP and Dr. Srinath Reddy. There's another question by Mayuri Padi, and this is to Shri, Keshav, Desiraju. Do we invest more on crisis management or preparation for crisis? Why isn't the latter given more focus by policymakers? I mean, you've touched upon it, but if you could.
Well, my only answer is, you see, we are a resource-poor country. So when there is no crisis, we somehow struggle, we continue, with what limited resources we have, we continue. Suddenly there is a crisis. Everyone's energies are pulled in, some additional money is found somewhere, and we work on that crisis. Now, I'm not saying this is a good way of working, but your question is, why does this happen? This happens because basically we're poor. If we do not have enough, or at least our priorities are such that we do not make enough to put into the sector. But a crisis has to be handled. So when a crisis arises, somehow the resources are found in some manner to tackle it. That's really all I have to say. Thanks.
Okay, thank you. And one last question before we move on to our chat questions. This is by Alaya Pureval, and this I can, anybody who wants to answer can answer. What are some nuanced socioeconomic and cultural issues that need to be addressed and understood in order to improve our Indian healthcare system? So maybe Dr. JP, you could start.
Dr. Srinath Reddy?
Yeah, Shri, Keshav, Desiraju.
Okay. Well, since the question has been asked, I think one thing we must all remember that in a very bad situation of access to health care, women have much less access to care than men. I think this has to be remembered at all levels, whether primary, secondary, tertiary. And again, as I've always been fond of saying, in this country, to be female, poor, and sick is a horrible combination. And I think at any level of healthcare, this needs to be remembered. What do we do so that the access to care becomes easier for women and that women are treated better than they currently are in our system?
In addition, I would say, if I may briefly intervene, I think there are a few issues which we have to increasingly propagate. The consanguineous marriages in South India. I'm sure Dr. Srinath Reddy will concur. That is a significant cause of childhood morbidity and congenital abnormalities, etc., etc. Or pregnancy is too young a girl, child marriages, etc. Those become increasingly less common. Or pregnancy at a very advanced stage for the mother. I think things of that sort, unless there is a strong social movement to educate people, I think we will not be able to really address it merely through medical care needs. And of course, hygiene. Hopefully, COVID will make us a little more aware of the sanitation and hygiene rather than the muddy and the traditional concept of pollution. And hopefully that will make things better. But I think there are some areas where conscious public education and cultural and social practices could be of great value.
Jayaprakash, could I just add to that? I think this also needs to include consensus about increasing the age of marriage, consensus about spacing between children. These are issues which, I mean, certainly in the southern states, there may be some understanding of this. But if you go to UP and Bihar, this is simply, it is simply not the case. And this is something where, it is what the community thinks, it is what people think that determines how people act in this matter. So it's also very important.
Absolutely.
Well, health beliefs and behaviors are also shaped by the amount of health literacy people have. It's not just a question of overall education, though overall education matters a lot. But even as we are trying to improve the educational levels generally, we must fast track health literacy so that people become much more aware and can protect, promote, and preserve their own health. At the same time, I must also say that it's very important that the healthcare providers themselves learn to be much more respectful of people and particularly not discriminate on the basis of people's income status or religion or caste. And those are some of the elements in the healthcare system itself that need to be tackled as social ills.
Dr. G.N. Rao, would you care to add something? Could you kindly unmute yourself? Yeah.
I think the biggest barrier for healthcare is lots of different types of inequity. As has been already pointed out, gender inequity, geographic inequity. And I think these can be, to a large extent, tackled by appropriate systems of care. My own experience is now with the strong system in the rural areas closer to the people. 54% of all people that we served so far turned out to be women. And we are actually aiming to make it achieve a 60% on that score. So that is, I think we found out if you make the access better, these people then seek care. So accessibility is an important issue in addition to affordability and availability. So that I think is an important fact.
Thank you, Doctor. Thank you, everyone. Now I'd like Vritti to go through some of our chat questions.
Thank you, Shweta. So we have received a couple of questions on the chat, but due to paucity of time, we'll be taking a few. So first question is by Maurya, and it's really interesting. So he says that often healthcare is not made an election issue. We all seem to know what needs to be done. Is COVID an opportunity to make it an electoral issue so that adequate attention is paid to it? I'll leave this question open to the panelists.
Okay, I'm willing to take the first crack at it. Well, one of the important elements is it can become an election issue if you talk about the neglect of the healthcare system in general and point out very clearly that unless you have a well-functioning and adequately resourced healthcare system functioning in the steady state in a non-emergency situation, you cannot suddenly build a surge capacity when a public health emergency arises. That's a lesson that is very evident to everybody in society now, whether it's policymakers or media or the general public. But these lessons are soon forgotten, especially by the policymakers and the parliamentarians and the legislators. So what we need is disaggregated health data for each parliamentary and assembly constituency, and we must challenge our public representatives at the time before the elections, what have they done to improve the health indicators in their constituency. Present them annually, the health indicators to track, and then challenge them. In Rwanda, even though it is much more of a almost like a one-party system, before parliament members are given tickets again for re-election, all the health and social indicators of their constituency are reviewed to see whether infant mortality has come down, immunization rates have gone up or not. So unless a public representative feels accountable for the health indicators of his or her constituency, you're not going to see that kind of political consensus and commitment built up.
Thank you, sir. Dr. JP, would you like to add to this?
No, I am somewhat optimistic. For long, health has never become an electoral issue in India, a political issue. But I think since 2006 or 2007, for the past 14, 15 years, starting with Andhra Pradesh, some of these smart politicians realize that health, focus on healthcare, not necessarily the way we look at it, but giving satisfaction to the people and patients about the out-of-pocket expenditure and catastrophic illness, they realize that there is actually political profit. That is the genius of Dr. Rajshekhar Reddy in Andhra Pradesh at the time. That's followed up by the Government of India model, roughly the same thing, this insurance-based tertiary care model of Ayushman Bharat. Delhi's Mohalla clinics recently, it appears that that has won significant public support and therefore one of the key reasons why they were re-elected. So I think there is now a tendency slowly, though belatedly, of health becoming an electorally significant issue. But the danger is, if it's not handled properly, the minimal resources available, in a resource poor country, as Keshav pointed out, if you don't design the right kind of programs, it will go to programs where there's an immediate patient satisfaction without improvement of health outcomes. Very much like the United States now, insurance-based, multiple health providers, competition for tertiary care, jacking up the costs, giving some kind of a satisfaction to the patient because he's not running out of pocket, but ultimately not improving healthcare outcomes. That is where the real challenge is. Otherwise, the system will drive India to high cost, low impact, populist model. But I think there is a beginning of healthcare becoming an electoral issue, but not necessarily always in the right way. I don't know what Keshav feels about it, but that's the sense I get.
Thank you, Dr. Srinath. Thank you, Dr. JP. Our next question is from Shruti Paturi.
Let Keshav respond if he has, sure, because he has seen it from 360 degree, 15,000, 30,000.
No, I see where you're coming from. I am not as optimistic as you. But then I think you are Foundation for Democratic Reform. So I think some of your democratic reforms should start here, working in the districts to see how people can get more interested in this. Thank you.
Thank you, sir. Our next question is from Shruti Paturi. She asks, countries like Italy and China have been able to flatten their curve post the lockdown. Despite a more stringent lockdown at an early stage in India, why we have not been able to produce similar results? Dr. Srinath Reddy, again, yeah, if you could answer this question.
See, firstly, China actually went in for selective regional lockdown, but they managed to do it with almost ruthless efficiency. They canceled all their domestic flights even before they canceled their international flights. And they managed to put down the spread of the virus very, very effectively. In our case, we went in for a general national lockdown without any differentiated strategy. And even when we unlocked ourselves, it became an undifferentiated strategy without adequate local surveillance systems being developed in terms of symptom-based syndromic surveillance, leading to appropriate testing strategies. Most importantly, adequate contact tracing. States which have done good contact tracing, whether it is Kerala or Andhra Pradesh, or even Punjab, Odisha, all of them have done much better. Whereas the failure of contact tracing in Delhi is so visible. So we have had a very inappropriate response as the lockdown was actually being eased. And the public health measures that have been greatly strengthened were neglected while policy was focusing mainly on hospital bed capacity and ventilators. I think these are some of the problems we had.
Reddy, if I may add to what Dr. Srinath said, if you look at in a broad sense, it appears that countries with strong state capacity to deliver, not merely make announcements, but actually deliver. The governments that enjoy a very high degree of public trust, a leadership that makes decisions transparently and evidence-based in a rational manner. And finally, already there is a reasonably strong foundation of a public health system. Where these four conditions exist in some degree, those countries seem to be doing well. Even if they are poor, Vietnam is a pretty poor country, poorer than India. But I think they have done pretty well because some of these elements are much stronger in that country than, let's say, India. United States, despite spending enormous sums on the world's wealthiest country, in some respects they have actually bungled. Though sometimes that bungling is overstated because some of the elements are missing. For instance, the public trust and the rational, evidence-based, transparent decision making. So I think there are some generic lessons also to be learned by India. There was a question earlier about preparing for a crisis versus crisis management. I think while we manage crises, I think we also have to do something at a relatively low cost in a resource poor country, as Keshav pointed out, to actually build some of our capacities. Otherwise, each time we lurch from crisis to crisis, and each time we are surprised, and we pretend or feign our incapacity.
Thank you.
Jayaprakash, can I? Hello.
Keshav.
Yeah, there was a message on the chat from the COVID nodal officer in Bihar. He wants to say something. I think we should listen to him.
Can you unmute him, Riddhi?
Sure, sir, I'll do that. Just give me a second.
Yeah, let one of you do that. Meanwhile, we can continue with until you can unmute you. Let's not lose time.
Okay. So our next question is for Shri, Keshav, Desiraju. The question is, do you think there is a resistance to accept alternate models of healthcare professionals, alternate medicines like Ayush, as a reason which polarizes the debate rather than thinking of an integrated manner?
Yeah, the answer to your question is yes, because we have systematically privileged what even the Medical Council Act calls Western systems of medicine. So since that has been a matter of state policy that Western systems of medicine is somehow desirable, it has meant that in the public mind, other systems, which are, they were referred to as Indian systems of medicine some 30 years ago, and now they're called Ayush. So yes, I think we need to be able, if we believe in this, as the government does, we need to do a lot more to promote them, not as an alternative to Western systems of medicine, but as a full-fledged medical system of its own, and leave it to those who believe in that system to avail of that freedom. Thank you.
If I may raise an issue there, Keshav. I don't know if there is two sciences available to the world. There are some areas where there's no Western science and Eastern science. If you have malaria, it's because of a parasite, and you require a drug to kill that parasite, period. There cannot be an alternative to that. If you have typhoid, if you want to treat it, it's a bacterial disease and there's a drug to kill it. Now you can develop other drugs like, in case of malaria, Chinese herbal medicine came up with artemisinin. But integrate those drugs and integrate. But there are some areas where things are not that clear, etiology, pathology, and treatment. And there I think indigenous systems are remarkably effective. So instead of looking at it as an integrated thing, if you look at it as a menu of options, you can choose this or that for malaria and typhoid. I think it's going to be very dangerous for the country.
You're probably right. Yes, I agree.
We have a couple of minutes left. So
1 second, Reddy, before I'd just like to get Abhishek to join in. Hi, Abhishek. You can unmute yourself and speak.
Yeah. Hello.
Yeah.
Good evening, everybody, all the panelists. I'm Dr. Abhishek. I work in a rural area. I'm nodal officer for Sirpur, Bihar. And I saw some chat messages that MO were scared and they should be held accountable. That's not the fact. And all the medical officers in rural areas, they have really been a frontline warrior. And they have, the area in which I'm working in, I have personally visited door to door all the villages, but I feel now that the policy of the government, if they would have consulted specialists like epidemiologists in this COVID-19 time, the scenario has been much more better and much have been in control. But the government, I think, he doesn't believe. I felt that COVID has been treated by bureaucrats and politicians. There was, I so many times I've told in the different webinars and newspaper that we must have followed the South Korean pattern. We should have introduced rapid test kit, which is more feasible, but still the government is not working on that. And the testing is so less that I can't even tell you. I'm talking about Bihar. The testing is really very less. So nowhere the MOs should be held accountable. The system in such a way that it doesn't want the testing should go up or something like that. So the no way doctors are frightened or something like that. I have been working for 16, 17 hours daily. But government should listen to us, that what we are telling, because we are the expert. Bureaucrats are not the expert.
He's right.
Thank you, Abhishek.
Thank you, Dr. Abhishek. I think Mrs. Sujata Rao has joined us. There were some technical issues earlier. Sujata, if you care to comment briefly, what do you think is the way forward? Could you unmute her?
Yeah, I have. Unfortunately, we can hear you, ma'am. Yeah.
What context way forward? Way forward in what context, JP?
What you have been fighting for half of your professional life, Sujata, and what Keshav has been fighting. How do you make health relevant to the future of the country in politics? And how do you make it effective in terms of outcomes at a low cost?
That's a very loaded question, and I think you won't spend so much time discussing. It requires a lot more time, but in the 2 minutes that we have, I'm getting more and more convinced that we have to, as a nation, focus on public health. And there is a certain amount of public health. I don't mean just government hospitals, but public health in the classical definition of what public health is. Just no technical capacity. In COVID, you know, politicians have taken over. You see in Hyderabad how KCR himself sets the testing strategy. I mean, I'm just amazed. And I'm also equally amazed. I don't know. I joined in just now because my internet has been terrible. Is also, I mean, I'm surprised that central government also not coming out with standardized protocols, which should be, you know, after all, health, this infectious disease and pandemic control is a concurrent subject. It's not a state is a health subject kind of argument you can take. It's in the concurrent list. So the central government is as responsible for what is happening today as a state government are. And if you see TB, malaria, HIV, very clear guidelines, very clear protocols, very clear SOPs, very clear direction. That comes from there. And it is for the states to then work around those guidelines and see and bring in innovation on ensuring the last mile effectivity. That whole center-state role has been mixed up. Public health specialists have been set aside, and it's a complete chaos. I really think that, you know, there's a lot of reform to be done. Having said that, I also want to say that I doubt if there is a stomach for that kind of a reform in this country. You can just go on and on saying the same thing again and again, but I don't see that political will, even after the COVID experience, to really get up, straighten our belts and get down to that kind of, you know, giving importance and pride. After all, it is a state responsibility. States must begin to understand what is the primary responsibility for which they are accountable. Not just pick any old thing, the lung transplant they'll do. It's not his business. That's not the state's business right now. And people are dying for much simple things. So, you know, this whole approach to healthcare, but there is no stomach. I was engaged somewhat with Andhra, but I find there too, you know, they just, a lot of things are being done, but it's a very different approach. I don't know how to get the dialogue onto the political table, and different agendas are being played out. Confirmed, you know, conviction to privatize at this time. That's again another, it will have its own repercussions. And the people engaged with policy making from the private sector, those who have failed to bring out a good financial model, Medanta, Trehan, that's failed. Apollo, I mean, all the corporate hospital people, their model of financing has failed. They themselves are not able to run their own hospitals. So, there is a lot of thinking, serious thinking that needs to be done, how that can be catalyzed and how it can be brought about. God alone knows. I really am at my wit's end in trying to understand which part of the problem do we all found. It's like a big elephant and seven blind men. Each one is catching on of different parts of the elephant. And there is really no coordination. That's what is going on. And there is no catalyzing of the whole experience, and everybody is just overwhelmed with day-to-day management of health. So I'm glad you have put a webinar for health. I think you should have some more and many more such discussions. And I just hope that the COVID experience, which has been an extremely painful experience, will teach us some lessons. And like in World War II, after that NHS was born. So also this horrible experience, I mean, as being compared to World War II, it really is in independent India. I don't think we've had such a bad collapse of the socio-economic system as we've seen happen now due to COVID. But we learn our lessons and really get down to working at it in a systematic fashion. I'm just very, very scared about what the 15th Finance Commission is going to do. There's so many actors in Delhi. 15th Finance Commission also has an expert group. Niti Aayog also has an expert group. Then you have ICMR also with an expert group. The Ministry of Health also has an expert group. So there is so much of one doesn't really understand what's happening. Only Srinath Reddy can tell us, because he's in the center of it all and tell us to say who's doing what. Because sitting in Hyderabad, I'm a bit confused. I don't know if these remarks have been helpful, but I've just had snatches of your conversations. So I'm just saying, in COVID, we could have done much, much better if only we, there was some amount of panic that we got led by and have made several mistakes. But this is not the time to think of that. It is to how to get out of the mess today.
Thank you, Sujata, for those insightful comments. Unfortunately, Srinath has an engagement at 6 o'clock, so he left us. Now, I think broadly it occurs to me that if you address the political leaders, elected leaders' desire to please their constituents, after all, it's a normal political need and incentive. If you combine that with a judicious policy mix, which will actually ensure good outcomes from the healthcare point of view, healthcare outcomes. I think if we somehow compromise between the two, there is a space open. As I said, I'm an optimist. I always am a glass half full kind of a guy. I believe there is a silver lining in a dark cloud. But do we have some time, a few minutes, Rithi, for a few more questions, or do we have to conclude?
We have already hit 6, but we can ask our speakers if they are okay with that. We can extend. We are technologically, we are fine with that. We can extend our session.
In that case, if you can take a few more questions of the remaining panelists. Keshav is here, Dr. Jayan Rao is there, and
yes, sir.
Sujata will also be able to help us in some respects.
So we have one very peculiar question. This is to Dr. Jayan Rao. The question is, to what extent is diabetes management critical to the management of optical health, given that it is a major risk factor for diabetes retinopathy? Are there any opportunities to integrate other primary healthcare providers to create a model that will reduce the risk of diabetic retinopathy?
Diabetic induced eye disease is one of the major threats for blindness in the country, one of the major causes of blindness. So there is no question that the general well-being of the patients with the diabetes is very critical. Controlling diabetes in such situations is #1 requirement to control any adverse impact on the eye health. Diabetic retinopathy, about 10% of all people who have diabetes would end up with diabetic retinopathy, and 10% of those people with retinopathy can go blind. So given that kind of a risk, there is no question that regular control of diabetes is very important. Whether that could be integrated, yes, there are several models where whenever we are dealing with people with diabetes, we work with other specialists in the area, and there is an integrated care of these patients. We look at the eye, the general diabetic specialist takes care of the diabetes, and if they have other problems like kidney or other things, concerned specialists take care of that. There is an integrated approach that's very much required there.
Thank you, sir. Next question is to you, again, Dr. Jayan Rao. So it is by Samruddh. He says, what is your take on the price caps on COVID-19 treatment charges? Would they not discourage more private hospitals from offering services?
What do you mean COVID-19 charges?
No, recently,
COVID-19 treatment charges.
some states, Dr. Rao Garu,
Yeah.
they have capped the charges private hospitals can impose on patients for the critical care of COVID patients. Would that actually help or hurt is the question. Private sector, if you regulate the fee precisely, is it going to help or hurt, I think is the question.
It's going to be a tightrope because from what I understand, the entire, if not 100% of the majority of the private healthcare people are under significant economic stress right now, because the normal volumes of other types of cases have come down significantly and incomes have come down. On top of that is the additional expenditure because of the systems we have to create for the safety of the patients for COVID. So that adds to the expenditure of these medical centers. So I think a balance has to be struck, and with a dialogue with all the providers, the government has to come to a reasonable compensation packages that is justifiable on both sides.
Thank you, sir. Our next question is by Tarusha Mishra. This is for Shri Keshav Desiraju. We understand that our big city management needs to be our next focus. So how instrumental can be the role of urban local bodies in effective delivery of medical services to the citizens?
Well, I think earlier in the conversation, this point came up about how urban primary healthcare is very crucial and important. The model needs to be different from a rural PHC. The nature of services offered, everything will vary. Certainly, urban local bodies will need to pay some of the costs. I mean, there are, for instance, Mumbai, the Mumbai Corporation, for instance, the Mumbai Corporation's health budget is probably massive. And Chennai is not as big as that. So the big cities certainly have the local bodies which have the authority to raise their own funds, having their own health setups. And there would be in Mumbai, again, corporation hospitals, doctors and nurses paid for by the corporation and all their stuff. Much more difficult for smaller and less well-resourced local bodies. But certainly, healthcare is part of the local body agenda. And if they are not in a position to raise their own resources, government will need to step in. Somebody who knows more about the 73rd, 74th amendments will need to examine this. But I'm sure urban local bodies are in principle in a position to raise funds for healthcare if they put their mind to it.
Thank you, sir. Dr. JP, would you like to add to what Shri Keshav Desiraju said?
No, I agree with Keshav. No, perhaps the Delhi, which is a city-state, no, basically we call it a union territory and we give the trappings of a state practically, but in reality, it is really the local government. It is perhaps India's most empowered local government, bigger than most local governments in the world, but stronger than any local government in India. Now, Delhi is already showing some dynamism in looking at healthcare, mohalla clinics, women. Dispute the model and details, but at least there is a robust model that is slowly getting rolled out. And I think the rest of India, we have to address that. As Keshav said, the PHC system was essentially designed to keeping in mind the rural India. It's not really suited to urban India. That's why when I was aggressively pushing for the National Health Mission. I wanted a national mission, not a national rural health mission. At that time, the political executive decided let's first roll out in the rural areas in RHM, and then to urban areas. And of course, what we wanted was something like a roadmap towards the National Health Service in Britain, but it's a truncated one. But I'm glad at least now they're talking about National Health Mission, but the urban part is not yet rolled out effectively to the best of my knowledge. But I think in the context of COVID, because this crisis is substantially an urban crisis, big city crisis, and urban poverty is becoming increasingly more glaring than rural poverty in India. Most people are ignoring that. I think that we have to focus on that, and local governments may or may not have the resources, but management can be given to local governments. Overall accountability, etc., subject to technical control at the state and national level. A resource can be supplied by the local government, as in the case of Mumbai, or partly supplemented by the state and union governments. But most urban local governments have reasonable resources, except that in Mumbai, where a lot of money is spent, I'm amazed to know that there are 1 or 2 medical colleges run by the local government. That is, I think, not really the right kind of deployment at the local level. I mean, that is somebody else's function. They should have focused on primary health and family health.
Thank you, sir. If we could take 5 more minutes, and if speakers have a question to ask to each other, we can start with you, Dr. JP.
Can I interject?
Yeah.
Sure.
Sujata, yes.
Yes.
For those who may not be familiar, Sujata Rao is the former health secretary and a distinguished civil servant, and spent about half of her professional life in healthcare. She was also primarily the author of the Health Commission report, I think about a decade ago or more. Sujata.
Just 2 points. That is, I think if we can really come to some kind of a consensus as to what are the broad characteristics of the kind of health system that we want, which really would delineate what primaries, private sector and the public sector that do 2 different roles can be delineated, so that this kind of confusion and different people talking in different voices is gone, and there is a certain consensus around it. And I see some hope only because the Kerala model of decentralization right down to panchayats has been shown to be remarkably successful. Delhi Mohalla clinics has been found to be successful, and many chief ministers are also looking at it seriously. In Andhra, a very interesting experiment has been launched recently, which has a lot of promise, where they want to have a village clinic right at the village of 2,000 population. It is expensive, but it is likely, I mean, if we do an overall cost-benefit analysis, it may turn out to be quite a good value for money that is being thought to be spent. So there is some amount of reorganization that's being done, and they have some other initiatives like mobile clinics that go to a village with a doctor and so on and so forth. So there's a lot of promise with what kind of interventions they are working on. So like that, I think Odisha is doing a lot on public health with help of PHFI and trying to see that primary care and public health get some. So if there is some agency or someone, maybe PHFI, I'm sorry, Srinath has left, they could document the different state experiences, which I was hoping that NHSRC could have done for everyone. It would be very nice to see whether we could have a blueprint, because each state has to have a different emphasis for public and private. Bihar, there's no point in trying to talk about private sector because there is nothing there. It's in a very, very serious question. Or the Eastern UP, there is just nothing there. So to go and say private sector and you think Apollo or somebody would set up a hospital, it's not possible. There's several other considerations that go into what can attract private sector investment and so on. So I think some of these issues need to be teased out, and if some kind of a platform can be generated in Delhi or something, it would be worth exploring that. And I don't know if FDR can be a catalyst in that regard.
Thank you, Sujata. As an aside, before I ask the panelists to give their concluding remarks, India is the biggest investment destination in education and healthcare in the whole world. It's an amazing fact. We get absolutely the highest investment in education and healthcare year after year. It means 2 things. One, there is a huge demand unmet. The services are required, needed, and at least some people are willing to pay enormous sums, sometimes impoverishing themselves. There's a demand unmet. Two, these investors are betting that Indian governments will never improve the public systems to a point where the private care at high cost will not be needed. The second fact bothers us a great deal. I think we should be really worried about it. While we should all encourage private sector, I'm a great supporter of private sector in general, but high-cost private services in critical areas of education and healthcare, particularly school education and public health, and to some extent the rest of the healthcare, if they are denied, I think the country is in peril, and there's no question of any kind of equality of opportunity, and poverty will be perpetuated. I think the young people who are participants in this webinar and many others, the professional group, the young group, the netizens and others, I think we have to raise our voice very consistently and robustly, at least to put healthcare in the center stage of public policy and politics, and two, to make sure that the money is deployed in the right way, not necessarily the popular way to get the votes. We understand the importance of votes, but do it the right way at a relatively low cost to get actually outcomes. The focus must be on outcomes. Dr. Rao, would you like to make a few concluding remarks?
Yeah. All that I say is that I hope the shock given by COVID and the lessons we are learning from this experience will show us the way forwards in creating a healthcare system in our country that is really equitable and services of good quality available to all people. Thank you.
Keshav?
Thank you. Just one very quick comment. I mean, this has been a very good discussion. I think one thing that has come through is that enormous contradictions in India between what is possible and what is actually happening on the ground, commitments that are made and realities. And I'm just looking again at your slides. You know, you have a slide somewhere which says that India supplies 40% of the world's vaccines. Our universal immunization national percentage is 62%. I think this is the kind of question younger people certainly need to ask, people in the health sector need to ask. Why do both these things exist at the same time? And I think the answer to that general question will probably give us many solutions to what we can do on the ground. Thank you.
I think Keshav raised a very important point. You know, India lives in different layers in different centuries, what some political scientists call prismatic society. Even today, while a significant section of India in terms of numbers, if not proportion, are in 21st century, a significant proportion are still in the 16th or 17th century. We're in varying layers. At least can we bring the bulk of the population to 20th century, if not 21st century? I think that should not be beyond our capacity, because in these days of technology and resources, where resources are always scarce anywhere in the world, I don't think that if we deploy resources well and if we really choose our areas of intervention, we are so incredibly short of resources that we are not able to improve the basic health. That 2,000 children are dying a day, that we have almost every indicator, the highest mortality and morbidity in the world. It's just not on. At the same time, when we paid attention, we could make significant progress from polio control to universalization of some of the immunization in the Determinants program, adding some more vaccines and so on and so forth. It's possible. We have strengths. As I said, I'm a glass half full kind of guy. We all recognize that there are problems, but we sometimes don't recognize the potential, the opportunities in this country. If there are no problems, there are no challenges, why do we require us? I believe that things can be improved. It may not be as good as we hope, but it can be certainly much better than what is today. Status quo is certainly not an option. I'm grateful to the panelists and to the participants for the huge response. We're sorry for constraints of time, we could not really continue the debate. But I think Sujata's point, we will take it forward. We'll have more than one, maybe much more focused in selective areas of healthcare, so that they can be a more rounded discussion and spread of ideas. And whatever we have discussed, we'll put it in the web for public domain, not immediately, but after a couple of weeks. Please do join us next week, this time, this day, Saturday, this time on agriculture. Each time we're taking up one or two elements of a sector. In agriculture, essentially focusing on supply chains and how to make the system work to the benefit of the farmer and the consumer. We're not talking of production. We're not talking of productivity. They'll follow the market. If the farmer gets an income, production will automatically improve. We should not talk about the government doing things to make something happen. We must do things to make the people do themselves, but creating an enabling climate. That's the idea. And the week after that, again, Saturday, we have big city governance where we are partnering with Janagraha, a very credible and reputed organization nationally in urban governance space. We believe these are initially 3 areas where COVID crisis opened up possibilities because it opened our eyes. Let's hope the crisis can be converted into an opportunity. 1991 crisis made us do some things in the country. Each time when there's a crisis, governments all over the world, they tend to move. Otherwise, inertia is a common phenomenon everywhere in the world, in governments, large organizations. But let's not despair. Thank you for your participation. And thank you, Reddy and Sweta and many others, Maurya and Keshav and many others for doing a remarkable job at very short notice. And we'll do it better and bigger. And thank you all for this wonderful participation.